Anyway, good morning, everybody, and it's very nice of the organizing group to have asked me to speak today, and thank you actually to all of you for having organized this and for the participants spending some time with us today doing this kind of thing. So as Denise indicated, I'm fairly experienced, dealing in issues with dementia. I'm going to try to leave a fair bit of time at the end for discussion so that questions can be answered and we can have a more interactive discussion. But I do have a number of slides, and I'll talk about some of the basics, and then we'll see what we get either from the chat bar or from our discussion. So I'm going to talk about this primarily more from a medical and psychiatrist point of view. Obviously, there's other speakers that are going to talk about other aspects of dementia itself and what it's like to be a caregiver, which I know is a very difficult and burdensome thing. Next slide, please. So what happened there? Okay, now, yeah, so we're at the right slide. So what is dementia? Just to define it, there's formal terms that can be used in terms of defining dementia, but essentially what it is a condition where there's memory loss, and it has to be persistent memory loss, and then it has to be combined with changes in at least one of the other spheres of mental or cognitive function. So things like changes in a person's language skills, like a person having word finding difficulty or not understanding language in the way that they did before, problems with learned motor skills. So that would involve things like no longer being able to dress oneself, having difficulty doing other complex motor tasks, things like feeding oneself, things of that nature. Another area of problem would be with recognition. You get people that have what's called visual agnosia, where they actually can't recognize their relatives anymore. They might simply not recognize them outright, or they may, for instance, just have a different view of the whole thing. They might look at their spouse and think that the spouse is not their spouse. They might remember their spouse as kind of the 25-year-old pretty young woman that they married, and they're not recognizing the 75-year-old mature lady that they're with today. They think maybe that's their mom, or that's a stranger, or somebody like that. And then the other area would be changes in judgment or personality. So things like becoming more prone to being financially taken advantage of. And these days with internet fraud and things like that, it's certainly easy enough to get taken advantage of. And things like changes in personality, either becoming more socially withdrawn or having personality changes where perhaps you're more boisterous, more sexually disinhibited in what you say, things like that. So there's various ways that can manifest itself in that kind of situation. And as I mentioned before, the problem has to be persistent, and it can't be accounted for by a medical problem. So there's people that we see in the hospital all the time that I see on medical and surgical wards where the problem is that they have delirium. So they have something like pneumonia or a severe bladder infection, or they've been placed in the intensive care unit where the days and nights are all the same, and they become delirious and confused. But that kind of thing in those individuals is reversible. And when the infection is changed, when they're physically better, they often go back to their normal state. And next slide, please. So there's actually many types of dementia, by different kinds of causes, but I'm going to talk today and focus on some of the more common types. So the most common type of all is Alzheimer's disease. There's vascular dementia, which is caused by strokes, mixed dementia, which is usually a mixture of Alzheimer's and vascular dementia, though it can be mixtures of other things, frontotemporal dementia, Lewy body dementia, dementia related to Parkinson's disease, And alcoholic related dementia is another fairly common one where a person, by virtue of having drank alcohol for many years, causes irreversible damage to their brain and cognitive function. Next slide, please. So Alzheimer's disease is the most common form of dementia. It's likely somewhere well north of 50% of all dementias. I know a lot of people think that dementia and Alzheimer's disease are synonymous, that they basically mean the same thing, but they don't. Alzheimer's is just one type of dementia, just the way a Ford or a Chrysler is a type of car. It's not all encompassing. So Alzheimer's is the most common type of dementia. Usually with Alzheimer's disease, but not always, there's a slow onset of the illness with progressive loss of things like short-term memory and some of those other skills that I was talking about, things like language skills, recognition skills, skills to do complex tasks and things like that. And if one was to actually look at the pathology of the brain, if one was to do a biopsy, which we really don't do in order to make this kind of diagnosis, but if an autopsy, for instance, of the brain is done, there's protein plaques, amyloid plaques in the brain, which are there, which do damage to the cells and to their function. This is an illness that can very much run in families. There are certain genes that make it more common to have Alzheimer's disease, the so-called apolipoprotein E4 gene. If you have inherited two of those genes, one from each parent, then Alzheimer's disease becomes pretty common and fairly likely. And with recent blood tests, you can show this kind of increased risk. Even some of these things that you can buy online, like 23andMe, often can give you results about things like this apolipoprotein status. So more reliably, that kind of thing would be done on its own through a hospital lab. Next slide, please. So if we were to look under a microscope at the brain, so in the normal brain, which we're seeing on the left as we look at it, the pretty neurons here, which are in purple, they have a nucleus and they're connecting with each other through these axons and dendrites, these kind of tentacles that they have, which allows one nerve to communicate with the other. And when somebody has Alzheimer's disease, in the space between the neurons, you get these amyloid plaques. It's an abnormal protein that deposits between the neurons in the brain, and it actually does damage to neurons, and it can actually kill some of the neurons and cause them to disconnect. And within the actual neuron cells, there's these things called neurofibrillary tangles, and again, these are abnormal constructions within the cells that the cells are starting to make, and they can do damage to the nerves and either cause nerve death or again cause them to not function the way they're meant to function. Next slide, please. So vascular dementia is the next most common type of dementia. In this type of dementia, the individual has unfortunately suffered one or more strokes that do damage to the brain tissue in a specific area of the brain, and this can affect memory and other mental functions. So as you can imagine, the particular damage that this does to your cognitive function depends on the exact area in which the stroke or strokes happen to occur. So if it occurs in the frontal part of the brain, then it might cause disinhibition and personality changes. If it occurs in the left temporal lobe of the brain, which is where a lot of your language skills are, then it might make it that you have trouble expressing yourself, or you don't understand language spoken to you quite as well. If it's in the rear part of the brain, the occipital lobes of the brain, it can actually affect your visual recognition of other people or of even common items and things like that. This kind of dementia can involve one large stroke, or often it's many smaller strokes. People who are, say, diabetic, have uncontrolled diabetes, etc., can get multiple tiny strokes, and this causes small bits of damage all over the brain, and can cause all kinds of deficits in function. So because this is potentially caused by strokes, which are either a blockage of arteries in the brain, or else a small bleed or hemorrhage in the brain, vascular dementia can have a much more sudden onset. And the other thing is that if you then control things like the blood pressure, blood sugar, and other factors, then the person may not have further decline unless other strokes happen to occur, or unless they also have Alzheimer's disease at the same time. So this is something where there's not necessarily the same kind of progression that one would often see in Alzheimer's disease. Let's go on to the next slide, please. So another type of dementia is frontotemporal dementia, and this is a type of dementia that occurs often younger. It often starts in a person's 50s or 60s. It used to be called Pick's disease after the neurologist who first described it, Pick. This is much more genetic in its cause. It runs more specifically in families, and up to 30% of people with frontotemporal dementia will have a specific genetic cause of this kind of thing. Because it's involving the frontal lobes of the brain, which I've already alluded to before, has a lot to do with your judgment and personality. Frequently in these kind of situations, it's things like judgment and personality that you see the initial impairment in, rather than memory. So I've met patients where all of a sudden they've become more boisterous. They've become having extramarital affairs, not as faithful to their spouses they've been for maybe 40, 50 years. It's totally out of character. They suddenly buy things like an expensive car, or other expensive items that they wouldn't, and obviously the family is kind of baffled and wondering why these kind of things happen. A person with this kind of change, because these kind of judgment areas are not working properly, might become much less empathic. They might not feel sorry for family members if there's a loss, or if something bad happens within the family. They lose some of their interpersonal skills and might become more blunt, and not as nuanced in the way they respond to questions and things like that. They might seem to be very insensitive all of a sudden. And this kind of dementia doesn't so likely respond to the cognitive enhancer medications that I'll mention a bit later, and that many of you, I'm sure, are familiar with. So at the bottom of this particular slide is a set of PET scan images. A PET scan is positron emission tomography. So these are very fancy machines that show things like the glucose uptake in the brain. Glucose is kind of the fuel of the brain, just like gasoline would be for a gasoline car, or electricity for an electricity run car. And if you look at the image on the left, and instead of the whole brain all the way around having nice red and green uptake of glucose, it's more this kind of cooler blue and purple area, where that part of the brain, the frontotemporal lobes, are not taking up glucose in the same way, and they're just not functioning in the same way. So we now live in an era where you can actually take an image of which areas of the brain are working and which are not, in kind of a moment by moment functional way, by looking at where the brain is using up energy. Next slide, please. Yet another type of dementia is Lewy body dementia. This is a type of dementia where frequently early on the person suffers from from visual hallucinations, seeing things or seeing people that are not there even, and having delusional thoughts. A delusional thought is a fixed false belief, being paranoid that you're being followed, being paranoid that that your spouse is being unfaithful to you, these kind of things. And often these kind of more psychotic symptoms occur, again, before the memory loss is apparent. And so it's not entirely clear at that point originally whether the person's having some kind of a psychotic episode or whether indeed this is a form of dementia. What happens later on is that the illness then also causes Parkinson's-like movement disorder. So it's not just affecting the memory centers in the brain and other cognitive functions, but it also starts to affect the area called the basal ganglia that have to do with your movements. And then the person may have tremors, resting tremors. They might have stiffness in their walking. They might have reduced facial expressions and things like that. The other thing about such individuals is that if you treat their psychotic symptoms with antipsychotic medications, they're a lot more sensitive to the side effects of these antipsychotic medications, and they might develop severe stiffness or tremors or restlessness just from the antipsychotic medication. And for a psychiatrist like Denise or myself, that would actually be a sign that, that yes, in fact, maybe this is somebody with Lewy body disease. And if you were to actually look at the brain on autopsy, you would actually see these tiny deposits all over the brain called Lewy bodies. And again, these are protein abnormal deposits in the brain that are doing damage to the neuron cells. Let's look at the next slide, please. So this is a pretty picture of a single neuron, and within this single neuron are these more orange yellow deposits, and these things are Lewy bodies, these abnormal protein inclusions in the brain, and these are doing damage to these neurons and can actually, again, affect the function of such a neuron, or actually kill some of these neurons in areas that have to do with memory, other cognitive functions, or indeed in the basal ganglia areas of the brain that have to do with our mobility. So this is where the injury and the damage in the brain comes from in this kind of case. Next slide, please. So how is the diagnosis made when we're looking at these various different types of dementia? So in the office of somebody like myself as a geriatric psychiatrist or a medical geriatrician or a neurologist or a family doctor, the most important thing initially is to take a history from the patient and the family to get an understanding about what the changes are in a person's memory, what their other cognitive changes are. Are they having difficulties finding words? Are they now having trouble with certain complex tasks, whether it be with dressing themselves, with driving, with managing their own finances, things like that. Are there personality changes? Are there hallucinations and delusions, etc.? A physical examination is important to rule out a medical problem, making sure that indeed it isn't something that's a source of delirium, that they don't have stiffness or tremors that show one of these Parkinson's-like issues potentially going on, making sure that the person isn't having something like a thyroid abnormality, which can make a person very lethargic and not able to concentrate, etc. In the history, we're also looking for things like depression, because sometimes very severe depression, especially in older people, actually looks an awful lot like dementia, and we call that pseudo-dementia. So from time to time, I actually do end up with patients where it looks like they have dementia, but indeed they're actually just profoundly depressed, and when we treat that, their memory comes back to normal. So we often then do a battery of blood tests, urine tests, et cetera, to rule out different things that can affect memory. Things like, again, as I was mentioning before, urinary tract infections, vitamin deficiencies such as vitamin B12 or folic acid, being hypothyroid and things like that. Next slide, please. We also often do brain imaging. So we can do things like a CT scan, computerized tomography scan to look at the brain and rule out things like shrinkage in the brain, rule out strokes, making sure that we don't have something such as a brain tumor, which would be something that obviously would need to be looked at and potentially treated, or to make sure that we don't have increased fluid pressure in the brain. So the brain inside it has these fluid-filled ventricles, and in some people, these ventricles can get blocked, and you can get something called normal pressure hydrocephalus, where the fluid pressure builds up, and it can cause memory loss. It also causes things like incontinence and a broad-based walking gait and things like that. And that's actually something where neurologists and neurosurgeons may be able to do something about that. Also available in this day and age are PET scans. I've already showed you one of these computerized images, and there's also something called SPECT scans.
3B, code white 3B, code white 3B.
Okay, sorry about that. So there's also SPECT scans, and it's kind of a poor man's version of a PET scanner. A PET scanner is a multi-million-dollar machine. There's probably under 10 of them around the city of Toronto, but here at our hospital, for instance, we're able to do an injection of a radioactive nucleotide that then causes markers in the brain, and we're able to look at images of the brain. And this, for instance,
code white 3B, code white 3B, code white 3B.
Sorry, I'm in the hospital, so that these things happen. So again, this would give an image. So if somebody had this frontotemporal dementia, for instance, you would see that their frontal lobes don't light up, and if they have Alzheimer's disease, there's a particular pattern as well. Next slide. So on the left is an MRI image sliced through the brain. And in this slice, this is something that's kind of typical of Alzheimer's disease. So there's shrinkage of the brain. So the normal folds in the brain are more prominent than would be the case in a person who did not have Alzheimer's disease because of shrinkage or atrophy in the brain. So this gives us some information. And then on the other side, the prettier color image shows that in the temporal and parietal areas of the brain, that there's more of the blue and the blue color, and even sort of more of this green color to sort of less take up of glucose in those areas of the brain than would be normal. Again, it would be better if I was actually showing you a comparative sample, but this does at least give us some kind of image result with this kind of thing. Next slide. So important issues to then consider once you've made a diagnosis of dementia, and when you're having this kind of discussion in the office with a doctor, for sure, the things that we often do look at are issues like the person's safety out in the community. Are they still safe even in their own kitchen? If it's somebody that is doing cooking, are they leaving the stove on, which is a fire risk? Are they leaving pans on top of the stove top or in a microwave oven or something like that, putting metal in the microwave oven and doing dangerous things. Are they able to use other appliances in the kitchen safely? If it's a man, are they doing things with power tools that are dangerous? I've certainly had issues with older gentlemen using chainsaws in a very dangerous way with dementia, or using other tools of that nature, and that can be very frightening, and it can be pretty difficult to convince individuals to give that kind of thing up. Do they still have proper ability to drive a car? Are they getting lost when they go out driving? Are they no longer obeying stop signs or traffic lights or things like that? That kind of thing again is very dangerous for the individual and is indeed dangerous for the community. Over the course of my career, I've been faced with patients who have done things like back over other people in parking lots by no longer being able to check properly. I've seen people who have gone onto the driven onto the off-ramp of Highway 401. I've seen people that have gotten lost to driving and then spent overnight by the side of a highway in a car. Got lost miles and miles from home and things like that. So that's something that's very concerning. And as a physician, if I believe that somebody is no longer able to safely drive their car, it becomes incumbent on me. It's actually by law something that I would actually have to report to the Ministry of Transportation. And that's something that becomes actually a very upsetting and emotional issue for many people. And I think perhaps men more than women, driving a car is something that they're very, very attached to and don't like giving up. We do live in a day and age of things like Uber and these kind of ride-sharing things where it's pretty easy to get around without a car. In a city like Toronto, it costs several $1,000s a year, as all of you know, just to own and operate a car. So anyway, it's, you do talk to people about alternatives in this kind of way, but it is a major, major safety issue. Is the person able to take their own medications? So often in the hospital, we get people that land in the emergency department because they've actually forgotten to take their medications.
Code white on 3B has been canceled. The code white on 3B has been canceled.
Okay, well, anyway, I'm glad the code white has been canceled. That's good to know. The issue with people's medications, so they do sometimes end up in the ER, as I said, because they've stopped taking their medications, and perhaps the person's a diabetic and they come into the hospital with a blood sugar that's massively higher than it should be. Maybe they're in a situation where they're hypothyroid because they haven't taken thyroid medication, their blood pressure is out of control, things like that. I've also certainly seen situations, and Denise has as well, where the person is so mixed up they take multiple doses of their medications at one after another. The person takes their bedtime medications, they don't remember that they did, they take it again. Maybe they take it a third or fourth time and they end up accidentally overdosing themselves, and that can be really dangerous. Is the person able to do things like shop for themselves? Are they dressing themselves properly, putting on their clothes in a way that they look normal? Are they bathing properly, making sure that they have proper hygiene, etc.? I was just in one of the nursing homes that I normally visit yesterday afternoon, and they had a fellow who hadn't been willing to go in the shower for about 6 months. And sometimes the person just doesn't think they need it anymore. Sometimes they believe that they had their bath or shower yesterday, and therefore it doesn't need to happen again. These kind of things. Also, sometimes people with dementia become a bit fearful of the shower. They don't like being supervised in the shower. They feel embarrassed about that, or they're scared about slipping and things like that. So there's various aspects of that, and those are concerning issues. Is the person managing their finances appropriately? Sometimes we get situations where the family only knows that somebody is slipping in terms of their cognitive function because all of a sudden bills and final notices are piling up, and it turns out the person hasn't been paying their property tax or their utility bills and things like that for many months, and then all of a sudden their phone gets disconnected, or there's threats to disconnect the electricity in the house or something like that, or indeed the person has been financially taken advantage of by some online scam or some telephone scam or things like that. And that's why it's important really for all of us, young or old, to make sure that powers of attorney are in place both for our finances and personal care. You don't necessarily have to do that through a lawyer. There's actually, if you look on the website of the Ministry of the Attorney General of Ontario, there's actual simple forms for this kind of thing that are there, and that can easily be filled out as long as you don't have a complicated estate. Having a will is very important so that the person's property goes to who they want, and also a living will that the person has expressed. Do they want to be in an intensive care unit if that needed to be? Do they want vigorous treatment if they were to be found to have cancer that was metastasized, et cetera? So it's very important for within families to have these kind of talks. And in my office and with my inpatients, we certainly talk about these kind of things early on. And you certainly want to do these kind of things before a person has lost their competency to make these kind of decisions, because at that point the horse is out of the barn, and it's too late to do those kind of things. If a person does not have a power of attorney with finances, then their finances would come under the care of the public trustee, a branch of the Attorney General's office. They'd have to be referred to the Attorney General's office, and then the family would have to go through a complicated legal process to get what's called committeeship of the person's finances. If we're talking about personal care, such as medical decisions, long-term care decisions, then it would be the closest next of kin that would be the decision-making person in that situation if there wasn't a personal care power of attorney that was assigned. Next slide, please. So I'll then talk a little bit about some of the medications that can be used for the management of dementia. So to date, unfortunately, there's really no cure for dementia. There's no real absolute panacea, but there are some medications that at least slow down the process from getting worse in the majority of patients. So the three most common cognitive enhancers, Aricept, Exelon, and Remenil. Aricept is known as donepezil. Exelon is known as ribostigmine, and Remenil is known as galantamine in generic terms. All of these are what's called cholinesterase inhibitors. They work to increase acetylcholine in the brain by stopping the enzymes that break down acetylcholine in the brain. Acetylcholine is an important neurotransmitter that helps our brain transmit information from one neuron to another. So in perhaps a quarter of people, the dementia actually gets at least temporarily a little bit better. In about a half of people, there's at least a slowing of the dementia over the coming 3 years. And in about another quarter of individuals, it really doesn't help at all. These medications work best if they're started fairly early in the illness. There's a number of possible side effects. These include things like gastrointestinal side effects like nausea and loose bowel movements, which go away. Exelon actually comes in a skin patch besides in a pill form. The Exelon patch where it absorbs through the skin. In Ontario, that's not covered by the government. You have to pay for it yourself, but the Exelon patch doesn't have those gastrointestinal side effects. There's also issues where you have to make sure that the person doesn't have things like a cardiac rhythm problem, because there's certain cardiac rhythm issues where these medications would be contraindicated. So often we end up doing an electrocardiogram before starting on such a medication. Next slide, please. If just push your button to advance this once, please. Okay, so anyway, so with this this little red line, so this is what it looks like over a 12-month period of time, starting the cognitive enhancer galantamine and leaving the person on it over the course of that year. The vertical graph is their cognitive score on a test called the ADAS-Cog. And in this case, so you're seeing that the person's cognitive function is improving a bit. It then starts to decline, but it's not declining to the same extent as the yellow line, which is somebody who's been on placebo, a sugar pill, for that period of time. Push the button one more time, please. Okay, so the person that was on the sugar pill for the first 6 months has now been put on the galantamine, and in this particular study, the individuals who are now put on the galantamine, their memory improves and then starts to go down a little bit again. They don't get back up to the kind of level of the group that started on it earlier, but there is some benefit. Push the button one more time, please. So that would be the trajectory of somebody who was just on the placebo, the sugar pill, for the entire year. And as I was mentioning, indeed, it does appear that for most people, these kind of cognitive enhancers are helpful for about 3 years. It varies from person to person. Sometimes one cognitive enhancer isn't working and you switch to a different one. But often these things, as I'm saying, for the most people, they are of some use for about 3 years. About 3/4 of people will have at least some benefit for 3 years. Next slide, please. So there's another cognitive enhancer, Ebixa, or memantine is the generic name of that one. It works on a different chemical in the brain called glutamate. Ebixa is more helpful for moderate to severe dementia as opposed to those other drugs which help mild to moderate dementia. You can actually use this medication in conjunction with one of the cholinesterase inhibitors, and indeed we sometimes do that. The Ontario Drug Benefit Program has not seen fit to pay for this. So just like the Exelon patch, if your loved one wants to be on this or you want to have them on this, you have to pay for it. Unfortunately, it's not covered. There are some provinces in Canada that do cover it, but Ontario, unfortunately, does not. Next slide. So there's a number of future treatments that are under investigation kind of moving forward. So there are a number of studies going on about anti-amyloid drugs. You'll remember those pretty pictures of the purple neurons that I showed you before, where there were these brown amyloid plaques that were between the nerve cells. So work is being done on drugs that would indeed eliminate and break down those amyloid protein deposits in between the cells and not allow that kind of damage to take place. There's an Alzheimer's disease vaccine effort that's going on. There were actually some significant open trials of Alzheimer's vaccines in several sites in North America a couple of years ago. There was actually some early approval of using an Alzheimer's vaccine by the FDA in the United States. They actually jumped the gun on it because there was such excitement about it. But when they did so-called phase 2 trials, there was a number of people with this particular Alzheimer's vaccine that got an inflammation of the of heart muscle called myocarditis, which was a really dangerous thing, and it had to be discontinued. In the initial trials of this, where they had given these vaccines to Alzheimer's disease mice, believe it or not, there's actually lines of genetically altered mice with Alzheimer's disease that are used for these kind of studies. The mice didn't get this myocarditis, but the people in some of these studies unfortunately did. So back to the drawing board on that. There's also the possibility moving forward of gene therapies. So as I was mentioning to you before, people particularly where this apolipoprotein E4 gene runs in the family are more prone to Alzheimer's disease. So there are efforts moving forward to look into whether gene splicing and replacing the ApoE4 gene and other genes associated with Alzheimer's could be done, and that this would be a curative sort of way to deal with Alzheimer's disease. So that's still somewhere down the line in the future. Hard to know where that exactly is at this point in time. There's also studies being done with something called transcranial magnetic stimulation. So transcranial magnetic stimulation involves using focused magnetic waves on the brain using a machine, something like the little cartoon that I've got there at the bottom. So we know that transcranial magnetic stimulation does work for some neurologic disease. As Denise knows well, it works for treatment-resistant depression in many people. We sometimes send people for transcranial magnetic stimulation, just the way we sometimes send them for ECT in some cases. But there are some studies going on, even one that's going on at CAMH at the moment, where people with early Alzheimer's disease can be trialed with the possibility of this slowing down the Alzheimer's process. Again, it doesn't appear to be anything that's in any way curative, but it is something that holds at least some promise. Next slide, please. So the other area that I deal in as a geriatric psychiatrist is treating the behavioral symptoms of dementia. Many people with dementia do have other symptoms that go along with it. Depression is common, especially early in dementia. Often the person is aware that they're having cognitive problems, and this can be difficult. There's the delusions and hallucinations that I've already alluded to before. Agitation and aggression can become problems in middle to later stages of dementia, and I would imagine some of you as caregivers have faced that kind of thing. So there's a number of medications that end up being used in these kind of situations.
Code white 3B outside the door of the diabetic clinic. Code white 3B outside the diabetic clinic. Code white 3B outside the diabetic clinic.
Okay, sorry, there's a bit of a disruption going on here with an agitated psychiatry patient. Unfortunately, it's relatively close to where my office is here. So antidepressants are helpful indeed when the person does have issues with depression. Some of these things like frontotemporal dementia do respond in some cases to antidepressants that can help with some of the disinhibited behaviors. When a person is having delusions or hallucinations or severe agitation, we sometimes resort to antipsychotic drugs. You have to be really careful with the use of antipsychotic drugs in older individuals. There have been studies done in recent years that show that there's at least a very small increase in the potential risk of strokes and heart disease, giving elderly people antipsychotic medications. And these drugs in some cases can cause stiffness or tremors or other side effects, unfortunately. Melatonin is an over-the-counter medication that can be used for things like sleep. Gabapentin is a drug that was originally marketed for chronic pain and also as an anticonvulsant medication for people with certain kinds of seizure disorders, but it is something that often will treat things like agitation in people with cognitive impairment. And Nabilone is a pharmaceutical grade medication. It has some relationship to marijuana, but without the THC in it. It's not the kind of stuff that you could actually go and buy in a marijuana pot shot these days. It's pretty carefully controlled in terms of the number of milligrams, and this is actually something that does help things like restless sleep or agitation and dementia in some cases, and it's a medication that that we resort to in some situations. Next slide, please. There's many behavioral strategies that that are useful and that are important. Things like music therapy can be very helpful for many people with dementia, and a person with dementia may have lost memory for many things, but indeed when music that's familiar to them is played, this often has a calming effect. They'll also often sing along and enjoy this and reminisce along with it. Pet therapy is something that's very helpful. Until the COVID pandemic, we actually had somebody coming to our unit every week with a therapy dog, and some of the nursing homes that I go to do indeed have therapy dogs, therapy cats, therapy rabbits even. Reminiscing with things like photos or videos is often extremely helpful, and these kind of things are very useful. Multisensory rooms are useful. I'm not sure if any of you have come across what's called a snoozling room. So we actually have this kind of setup here. So it's a rather fancy apparatus that shows kind of calming slides of settings like beachfronts and things like that. It shows calming music. The person is sitting in a fancy lazy boy style chair, kind of leaning back. And there's even these kind of tactile fiber optic little cable types of things that they can feel and touch. And it gives them kind of a different sensory experience, and it's really relaxing. As kind of a busy psychiatrist, there's days where I feel like going and sitting in the snoozling room in the chair and calming down with this kind of thing. But we do find that it actually is calming, and at least a few of the nursing homes that I do outreach have these kind of setups, which is really great. There are devices like video monitoring, particularly if the person with dementia isn't living with you. Some families have video set up so they can monitor the person to some extent. If the person is a wanderer, there are GPS devices, bracelet devices, et cetera, that can be put on the person to make sure that they don't wander away. You have to make sure that the person doesn't cut the bracelet off and things like that. When we were doing this kind of forum live, I think some of the vendors that we had were people that offered these kind of devices. Having a lifeline device where if they fall, it sets itself off is very useful. Adaptive clothing is something that's very helpful. So if a person is now having trouble tying their shoelace, Velcro closure shoes are very helpful. If they're having trouble with buttons, even if it's from arthritis, let alone their dementia, then that kind of thing can be helpful. There's individuals who have severe dementia and strip off their clothing, and there's adaptive clothing that help with stripping and things like that. And there's also things like locks and other safety devices as well. Next slide. The other point that I just wanted to make is that it's also important to control things that would be considered cardiovascular risk factors. So anything that's good for the heart is good for the brain as well. So you do want to do things like control things like blood pressure, blood sugar, cholesterol, things like smoking cessation, etc., and be on a heart smart diet. Next slide, please. Exercise is really important. It's important for all of us, frankly. People that do have mild cognitive impairment, there is some information these days that shows that exercising, it releases endorphins in the brain that helps your mood and your memory. It may cause something called neuron growth factor to be produced in higher volume and may cause some increased nerve cell connections in the brain. It may in fact reduce the incidence of Alzheimer's disease, and it does help with things like executive function in many people. Next slide, please. Mental activities are very important. Things like different brain exercises, taking classes, crosswords, word puzzles, Sudoku, things like that. And there's books with various strategies of this sort. Next slide, please. And here's kind of a number of resources that I particularly recommend. The Alzheimer's Society, which is one of our participants today and one of our co-sponsors of the event, they have a wonderful First Link program that is very helpful for caregivers. They have different other resources. One of the books that I've found very helpful for my patients is a book by Dr. Gary Small from UCLA, talking about different strategies for dealing with dementia and maintaining cognitive function. He's a very, very bright doctor in this area. I've had the opportunity to meet him on a couple of occasions. CABI, which is at Baycrest, it's the Center for Aging and Brain Health Innovation. You might want to look at their website. They fund a lot of innovative projects about different devices and ideas that are helpful for families and people with dementia. I have a brother who actually works there as the business director of CABI, so I do have some family connections over there. There's an American company called TruAlta that actually does online training for caregivers in terms of how to help and deal with somebody with dementia. And the Reitman Center, which is associated with Mount Sinai Hospital, they have a dementia advisor app that you can buy on the App Store very easily on your cell phone, or they do have a website as well. So I'll leave it at that, and I'll leave a bit of time for questions. I was hoping to leave even a little bit more time, but we'll leave it at that. Thank you. There's a cartoon of Sam from the Green Eggs and Ham books, which are Dr. Seuss books. I'm not sure whether poor Sam is having an identity crisis or perhaps his problem is dementia at this point in time.